All right, picture this. The call comes in over the radio. You've got a patient who's dizzy, totally out of it, and their heart is just crawling. It's dangerously slow. Time is ticking, and every single move you make matters. Today, we are going to pull back the curtain and decode the protocol that guides medics through this exact situation. Let's get into it.
So, first things first, what are we even talking about? The official term is bradycardia, and in plain English, that just means a heart rate that's too slow. The magic number, the cutoff, is usually under 60 beats per minute. Now, for an elite athlete, that might be totally normal, but for most of us, yeah, that's a big red flag that something is really, really wrong.
And that really gets to the heart of the matter, doesn't it? I mean, a slow heart rate isn't always a five-alarm fire. So when is the tipping point? At what moment does a paramedic look at their monitor, see that slow number, and know they have to act, and act now? Well, figuring that out is what this whole protocol is designed for. Okay, so before you can treat anything, you have to play detective. The very first step is always investigation. It's all about reading the clues the patient's body is giving you to figure out what's going on under the hood. Think about it. When the heart slows down too much, it's not pumping enough oxygen to the rest of the body. And your body is going to start ringing some serious alarm bells. The patient might feel that classic chest pain or feel like they just can't catch their breath. They could get super dizzy or even pass out completely. It's all because the brain and the other vital organs are starving for oxygen. So while the patient is feeling all of this, the medic is running a rapid-fire diagnostic in their head. Is this a heart attack in progress? Could the patient's own pacemaker have failed? Maybe it's a problem with the heart's internal wiring, something called an AV block. Or could it be something totally different, like a drug overdose? You have to consider everything to nail down the real cause. And all that detective work, all those clues, they all funnel down into this one single, absolutely critical question. This is the decision that changes everything that happens next. Is this patient stable or are they unstable? This right here, this is the fork in the road. It splits the whole treatment plan in two. A stable patient, while they're not feeling good, they're dizzy, they might have some chest pain, but they're awake, they're alert, and their blood pressure is holding steady. An unstable patient, though, that is a whole different ballgame. They are showing signs of shock. They're confused, their skin is pale and sweaty, and the big one, their blood pressure is in the toilet. It means their body is losing the fight. So once that call is made, stable or unstable, the paramedic has a very clear action plan. So let's follow both of these paths, and we'll start with the patient who's in less immediate danger, the stable patient. Let's talk about pathway 1, the stable but still symptomatic patient. For this person, the goal is to be gentle. We're trying to just encourage the heart to pick up the pace a little bit. We're not bringing out the heavy artillery just yet. We're just giving the system a nudge back in the right direction. The primary tool for this job is a drug called atropine. You can think of it as a chemical kickstart for the heart. You give 1 milligram as a fast push through an IV, and you can repeat that every few minutes, up to a max of 3 milligrams. Now, if atropine isn't working, or if it's not the right choice for some reason, there is a plan B, push-dose epinephrine, and that's used much more carefully to just bring that blood pressure up. Okay, let's slam on the brakes and pivot to that other, much scarier side of the fork in the road, the unstable patient. Notice the language here is different. We're talking about shock. Poor perfusion. This is a life or death situation, and the response gets way, way more aggressive. Now, even within this unstable pathway, there's another crucial question to answer. Is the patient so unstable that they are on the absolute brink of death? We call this peri-arrest. This person is barely conscious, they are not breathing, or maybe they're just taking those awful, gasping, agonal breaths. They are literally seconds away from a full-blown cardiac arrest. For a patient in peri-arrest, you do not wait. You don't hesitate. The protocol is crystal clear. You start chest compressions right away, just like they were already in arrest. You push the full cardiac dose of epinephrine, that's 1 milligram, and after 2 minutes of CPR, you check for a pulse. If that pulse is gone, boom, you've already rolled right into the cardiac arrest protocol without missing a beat. But what if the patient is unstable, deep in shock, but not quite in peri-arrest yet? Well, this is where you throw everything you've got at them. The number one priority is something called transcutaneous pacing. You're basically using pads on the chest to act as an external pacemaker, electrically forcing the heart to beat faster. Now, that can be pretty uncomfortable, so sedation is a good idea. At the same time, you're giving that push-dose epinephrine and a big slug of IV fluids to get that blood pressure back up. So we've mentioned a couple of really key medications so far. Let's actually zoom in on these tools for a second, because how you use them, well, the details matter a lot. Let's put these two drugs, atropine and epinephrine, side by side. You can see right away how different they are. Atropine is a bigger dose, 1 whole milligram. You give it less often, and there's a hard stop at 3 milligrams total. Push-dose epi is a tiny, tiny dose, just 20 micrograms, given more frequently every 2 minutes. And the goal isn't just to jam the heart rate up, it's to gently nudge that blood pressure back over 90. See? 2 very different tools for 2 very different situations. And this push-dose epi isn't something that comes pre-mixed in a box. Paramedics have to make it on the fly. They take just 1 milliliter out of a standard cardiac epi syringe, and then they dilute it with 9 milliliters of saline. What that does is it creates a much weaker, much safer concentration that lets them control the blood pressure precisely without sending the patient's heart into overdrive. It's a really critical skill. When you look at all these steps, it feels very structured, very logical. But at the end of the day, a protocol is just a map. It shows you the best way to go. But it's the paramedic's own judgment, their ability to read the patient and the situation in front of them, that actually navigates the ambulance through the storm. And that kind of leaves us with one final thought. In a completely chaotic scene, with alarms going off and the clock ticking down, having a clear, evidence-based process like this, well, it does more than just make things simpler. It saves lives. It takes the guesswork out of the equation. It really makes you wonder, how much does having a clear pathway like this truly stack the odds in the patient's favor? It's got to be huge.